welcome back all to the podcast, episode number 3 or 4. And we've got a good one for you guys. We're talking about high risk meds in older adults, which is like near every med known to man, which we'll come back to. But until then, I had such a desire to record side by side with Caitlin, but because she refuses to do that,
Yeah.
then I got this picture behind me here of the Smoky Mountains. So we
Yeah.
talked about it before. Caitlin is somewhere in this ballpark. If you're listening in, you'll have no idea what I'm even doing or what I'm even pointing to. But if you're looking at the YouTube, then this is where Caitlin's at.
Right there.
Right there. You can't even read the note, but I put Caitlin is here. She's right there into that tree recording.
Just hanging out.
It's incredible. So did you build like just a one-room shack that you're
Yeah.
in
Oh, yeah.
recording?
Yeah,
Got
there's
great
a lot
Wi-Fi
of
there too.
reels on how to do that.
Listen, y'all, before we get on here, most people probably go over what they're going to be talking about. We, on the other hand, have a different approach, and we think that this approach is probably the best approach. Willing to give other podcasts ideas on this, but we get on here and we just talk about pretty much anything.
Just
I mean,
wing
I
it.
was asking her, Caitlin, y'all just started listening to some Christian music here recently,
Mhm.
and she's like, I don't know any of the artists. And I was asking, do you know Phil Wickham? I don't know if they call him like Wickham together, like just put it together. I don't think anybody's ever called him that. Probably he'd be offended if he heard that too. So sorry, Phil. My bad. Pray for me. But then we were talking about Brandon Lake, which if you are
Yes.
a Christian, like he's so good.
Mhm.
And then you were like, well, what's that one artist's name? And I was thinking you were going to say Jelly Roll, because Jelly Roll and Brandon Lake did that
Yeah, they
song
did. Yeah,
and
that's a good one.
it was so good.
But that's not my
But that's
favorite.
not at all who you brought up.
No.
You brought up, isn't it Alex? What's his name? Alex Warren?
Yeah, with Luke
Y'all know who we're
Combs.
talking about, right? He's the dude that did the
Ordinary.
Ordinary song. The Ordinary.
That and
That one?
Chris Stapleton with the Steel Drivers. They have some good Christian-based songs. It's like
Oh,
more
yeah.
bluegrass. It's before he did the Traveler album. That was a long time ago.
A long time ago.
Mhm.
Yeah.
That's really good.
Yeah, his voice is just is
My
awesome.
favorite. Yeah,
Oh,
my
it's so
favorite.
good. And we were talking about Need to Breathe. I don't know if you guys have ever heard Need to Breathe. I just went and
That's a
saw
good
them
one.
in concert. They were doing their acoustic series up at the Choctaw Casino in Durant, Oklahoma. And if you're from Durant, shout out to you. If you're not from Durant, you likely are going to call it Durant, and we're going to know you're not from Durant, Oklahoma. Which is hilarious because that does come up. I mean, I'm down here in Texas right now, and everybody's like, are you going up there to Durant? To Durant? I can't even say it right. To Durant, Oklahoma, or wrong, one or the other. And I'm like, Durant? And they're like, what'd you say? Like, no, Durant, Oklahoma. They're like, yeah, Durant. Okay, we're not saying the same thing.
That's
But
not the
yes,
same
went up
place.
there with my beautiful wife, and she took me on a date up there to see that concert. So good. I may or may not have cried during a couple of songs because it's just incredible. They're just, if you never listen to their music, it's like when he's going through something is when he writes a song, and it's like, or when they're going through something, they write a song.
Mhm.
And I just love that, like raw and honest. None of this fluff that we get on like everything nowadays. Like,
Do you listen to
life is
John
great.
Rich's
Hashtag great.
songs?
Huh?
John Rich, like he went off and
Who's
did
that?
some. So you remember Big and Rich Ride a
Oh,
Horse?
yeah.
So he he went off and did some Christian songs on his own. And
Oh,
same concept. He was writing it as he was being spoke to, and he was going through things, and they are so powerful. I think that
really?
that's really kind of a defining moment when it comes to how the music feeds through you, is like when they are being spoke to and they're going through those
Right.
things, that it makes it so powerful. Yeah, his is
Yeah.
really good.
Yeah. It probably, I mean, whether you're somebody that likes to talk about like your problems that you're going through or not, I feel like I'm somebody that's just overly open. I probably don't need to be,
Yeah, I'm the
but
same way.
I mean, I just tell like somebody who's standing next to me at Walmart, I'm like, you know what? Today's been a terrible day. And they're
But at
well, I'm
least you're
just trying to
getting it out
check out
before you
here.
go
I'm
home.
just in the self checkout line. I'm like, look, this is a therapy session. Here, get over here. Let's talk
Yeah,
about it. What's been going on in your life? And that's, and they're like, um, I'm just trying to get home.
I'm just here to return this
Have you
home.
ever gotten in line behind, we were talking about this the other day at church, and how people react to this. Have you ever gotten in line at a store, which is few and far between now, I feel like with all the online ordering and Amazon and everything else, most people don't stand in line anymore, but have you ever gotten in line at a store where somebody is paying with a check?
Yes. It's been a while, but yes.
You think people go lose their faith right there
Yeah,
at the end of the day. I
yeah.
mean, it's like, you got people that are behind you and they're just like,
Just
everything's
ants
like,
in their pants. Yeah.
yeah, they're like, "I
Mhm.
can't believe this person up here paying with a checkbook balancing it."
Yeah. But that was what everybody used to do.
I'm always just like, if you need to go, you can go in front of me. I mean, it's one spot up. I don't know that that's really gonna help that much, but here you go. And then they're probably always thinking like, "Well, are you gonna pay with a check too?" Like like what? You caught
Probably
the drift.
just 'cause.
Yeah, just
Yeah.
trying to be helpful.
Yeah.
All right, well, all that, talk aside, and we could just talk for hours about that. In fact, we may interweave some dialogue from our crazy lives in here, but we wanna talk about high risk meds in older adults and the why behind it. And we've got our notes right here. We're ready. We're armed with the info, but we're also armed with the info of personal experience in this realm of doing this for many many years of consulting. Um, but this should come as no shock. Goodness, I need to silence the notifications on my phone. They're like constantly going off. It's like I need one of those safe things that you can put your phone in during podcast recordings and nothing can come out or go in or whatever till it's over. But um, older adults, the why behind it, well, obviously these are frail, elderly, vulnerable population. They're prone to polypharmacy, which if you're new into the long-term care space, that means a whole junk ton of drugs,
Mhm.
and they have got those. In fact, in this setting, it's not uncommon for us to see, and I think we talked about this on one of the initial episodes. It's not uncommon for us to see a drug given to treat another drug's side effect, and that's been done that way for years, decades, perhaps, in somebody's life, and they've gone through several different doctors. But polypharmacy, they've got lots of comorbidities, got lots of like age-related metabolism issues, which is what we see with the way that our bodies don't work as well when we get older. And then, right, Caitlin, the hospitalization rates are way higher.
Mhm.
What did we find? How much higher was it? Was 65 and up compared to younger
Seven
adults?
times higher for
Yeah,
them to go into a hospital for side
seven
effects.
7 times higher.
7 times higher.
And then
And I
we see
think
them
a
go into
lot
the
of
hospital.
times,
Oh,
yeah, and
yeah,
a
go
lot of
ahead.
times they don't really associate that hospitalization with the drug. I think it's one of the most underrated findings in hospitalizations. But still, with even that said, we know it's projected to be about 7 times higher in that
Yeah.
age group.
Yeah, and then we see the whole cascade effect of that, right? Where they go in to the hospital, they get put on an antipsychotic to keep
Yeah.
them, from causing any issues or whatever. Sleep is a big one too. And then they come out on the antipsychotic, med profile's all messed up because they haven't gotten any reconciliation done depending on the hospital. I'm not bashing hospitals out there. If you're a hospital pharmacist and you're doing med reconciliation, praise you and in your efforts because that's not what is happening at every hospital out there that we see. And so we see this kind of cascade effects. We see patient safety issues, cost issues, all sorts of things, quality of life. And we'll talk more about that in a second. And when we think about the high risk meds, you might be wondering what meds are those? We use three or more criteria for this. The first one you may or may not have heard of, American Geriatric Society Beers criteria. Um, that's kind of a gold standard, I guess. Most people think of the Beers criteria or stop start criteria that comes with all these. I think that's more of a European guideline, but those two are ones that a lot of people talk about. And we were joking around earlier. We kind of said, well, that's like basically every drug that they're on,
Yeah.
but it's not really a lie. I'm pretty positive that if the Beers criteria, let's just say there was 200 drugs that every elderly person took, I'm pretty positive Beers criteria would have 205. I mean, I
Yeah.
don't know. I mean,
Absolutely.
it's
I
it's
wish they would just
crazy.
make it to tell us what to do. Like,
Right.
yeah.
Well, what am I
Be nice.
supposed to give?
Right.
Because we laughed about like hypertension. There's so many meds on there for that. And you're thinking, well, what do I even give my person? Because a lot of these people are on these meds. I think the big thing is when you look at those two criterias, they highlight the potential for inappropriate use in this population. And it probably doesn't sink in to most clinicians, pharmacists, doctors, nurses, etcetera, how many drugs might be inappropriate for these residents. And so if anything else, it just maybe brings light upon the fact that you need to think about what that person's on, especially for us consultant pharmacists that are out there. Um, and this is not uncommon. I just reviewed an assisted living the other day, and in this assisted living, they have drugs started that they didn't even do the initial drugs that you're supposed to do first before you even get to those kinds of drugs, and right, and so now we've got this person that's got potentially a bunch of adverse effects because we didn't even try the ones that have less adverse effects that have been proven to be more effective in that population for that condition. So and then there's ISMP, which has their high alert med list. And we'll try to drop a link to this in the show notes because I think this is a fantastic list. But we'll kind of come back. This is looking at harm, and there's a specific set of drugs that they look at, which we can kind of move into next, Caitlin, if you want to mention some of those to our listeners and viewers.
Yeah. So, an example of some of those medications: opioids, anticoagulants, insulin, chemotherapy, and then your psychotropic medications and anticholinergic. That's a big one we look at a lot. Antihistamines. What else, Scott? That's pretty much the big ones.
Yeah, that's pretty much the big ones. I mean, we're kind of working our way through the sedatives and hypnotics. We did
Yeah.
an episode on that last time. We're working our way through. I misspoke, but we're working our way through the psychotropics that are in long term care, and we wanted to take a little bit of a break because you might want a med for if you keep listening to
Yeah.
this
It's heavy.
these talks on this. You might diagnose yourself after you hear some of these and go, "Oh, I think I've got that too." But those are a big one. We see a bunch of
Mhm.
the psychotropics, antipsychotics, tons of anticholinergic properties. The anticholinergics, which you mentioned, are very prevalent.
Yes.
Um, there's something that we do in this setting It's called, calculating their anticholinergic burden. So for those of you that are not pharmacists listening in, that would be their risk of having the anticholinergic side effects of these medications. And those things would be like confusion and constipation and urinary retention. And you can
Mhm.
automatically kind of key into some of those and go, well, yeah, confusion. Well, then they may be thought that they have dementia or, along those lines, or constipation. And if you're a nurse listening in, that leads to a potential impaction that can be life threatening, right? So when we think of anticholinergic burden, it's sad, but a lot of these residents have a pretty high
Yeah.
anticholinergic
Mhm.
burden. Um, Yeah, and then cardiac drugs like digoxin is one that's on the ISMP, um, high risk med list. Why? Well, it has a chance for toxicity. And you may say, well, I've never seen anybody digitoxic. I actually have seen somebody digitoxic, so it can
I have
happen.
to. Yep, I have to.
That's why we run the levels on digoxin.
Especially
So
when
if
they first
you're,
start.
yeah, and if you're one of the nurses that are listening in and you're going, why does this pharmacist always recommend all these labs? If you're one of the DONs or even a floor nurse or whatever, it doesn't matter. You guys are going to see the labs. That's why
Mhm.
we order labs to monitor for toxicity and treatment levels. Um, and then all the diabetic meds are
Mhm.
a huge risk,
Yep.
especially sulfonylureas with insulin that increases the risk of hypoglycemia massively. And so then you just have all the other things like you were mentioning that the opioids, which it seems like almost every resident that has any pain is on an opioid. Um, I, you know, I've never really, I remember having a surgery one time and getting a script for Norco, and it didn't work well for me at all. Like, I mean, I think it works well for some people, but just to illustrate the different ways that we metabolize and
Mhm.
the different ways that drugs affect one another, um, it didn't really work on me. I just took ibuprofen and it was perfect. But then you got the NSAID issue for this population where poor kidney function and kidney injury and chronic kidney disease. And so there's all these like kind of things that we were talking about earlier where you have polypharmacy, where you got these multiple drugs on there. If you're having some of the anticholinergic side effects, you've got drugs to treat some of the anticholinergic side effects. If
Mhm.
you've got, comorbidities like chronic kidney disease, things like that are going to increase your risk of having issues, adverse effects with these high risk meds. And there's a lot of real world consequences, right? Caitlin and I see this probably all too frequently.
Mhm.
We mentioned one of them, and then Caitlin, I'll let you talk because sometimes I just get on these little like tangents and I just start talking away. And then I'm sitting there and Caitlin's giving me, I took there was a screenshot that Riverside, which is the platform that we use to record. Oh my goodness, this was a perfect screenshot. I was talking. It's kinda like the video that I posted the other day when it looks like I was sleeping when Kayla was talking. We are constantly always giving each other these looks and stuff during
Mhm.
when we're talking, but there's this screenshot that it prepped it for me. It said, "Here's something for you." Like, "Here's a
It's
gift
almost
for
like it was
you."
telling on me. Like, here you go,
Well,
here you
or
go,
telling
this is
on
a present.
or telling on me, maybe more like it. But it was like, "Hey, shut your mouth, Scott. Look at what your co-host is doing." And it had this picture of me talking, and Caitlin is legit rolling her eyes at me. So
No, no, I would never.
mhm, it was caught on camera.
You
Caught
know,
on
it just
camera.
looked that way.
I
Mm.
mean, my wife does it to me. I might have just ignored it. I might have seen it and be like, "Oh, I've seen that before."
You just don't even flinch to it.
It
Mm.
just doesn't affect me as much anymore, I guess. But back to the real world consequences, Caitlin.
Yes.
Let me pause for a
Mm.
second, get some coffee, and you
Yeah.
tell them some of the real world consequences.
Oh my gosh, where do you even start? It's so big. I feel like it just they stack on top of each other. And I was just looking at a facility, and I mean, I text Scott about it too a couple weeks ago. And this is pertaining particularly to like CNS depressant or active agents. And I ran across like this 92-year-old woman. And if there's a high risk drug, she was on it. And not just in low doses, but in high doses. And it just looked exactly like what Scott was talking about. It was like we started this med somewhere along the line out of these 10, and we started tacking on other meds to kind of combat side effects. Like it was the highest dose Abilify injection, gabapentin, Ambien, Ativan, opioids, muscle relaxers, antidepressant, aspirin. And I was just like looking, and I was like, oh my. And she's just this itty bitty little, little thing. And it can be really difficult to trying to get the physicians for me to buy into it because in their mind it's like they're stabilized, they're stable. And you can make a recommendation, if they've got 12 meds, it's like, well, which one do we start with? How will you know which one's the causative agent that's causing the biggest issues? And it's sometimes like shooting in the dark, just based off of like what you know about the meds and how high risk they are and going through their medical history and the best that you can and making recommendations to lower doses and not just gradual dose reductions but just lower doses of other meds and see what happens. It's difficult, but I feel like almost 80% of the residents I see in each facility have polypharmacy and are on at least 2 to 3 high-risk meds of all sorts of different classes of drugs. And I understand that, with long-term care, these are the sickest in a lot of cases of residents with the worst disease state management because they're not at home. They're unable to be at home. So, of course, they're going to come with the most complicated comorbidities. And that also makes things more difficult to see through that. But as they get older, they stop eating, their appetite changes, these meds are affecting them. One that scares me the most, and I don't know that it should, but it definitely does, is insulin. When I see type 2
Yeah.
diabetics on 100 units and sliding scale or just long acting 100 units of high dose, I'm like, well, the moment they decide not to eat, the moment they
No, I
decide
know.
not to eat or not eat as much, that's going to bottom them out. And so it's alarming and it's difficult, but I think you just have to keep educating and throwing the information out there. And if they don't bite on that drug, try another one, because ultimately they're the ones trialing, your recommendations to see if it works. And chances are there's another one that you could ask that might benefit the patient and might show, some improvement and their quality of life. And then also the nausea, taking that many meds like that at one time. These patients are getting all these meds in one cup,
Yeah.
9, 10, 11, all on their stomachs like that. Some of them eat a lot, some of them don't eat a lot, and that's sitting in their GI tract and, absorption all at one time. So I
Yeah.
think there's like, there's a lot of, things to address with high risk meds and looking at their medication list and just keep on trying to, bring physicians, nurses, and people to the table to see what best fits the resident at that time.
Yeah. It is an overwhelming challenge. I was listening to you thinking of how many stories I've heard of residents that are nauseated or sick. I mean, my goodness,
Yeah.
like that whole pill. I don't even want to take pills or meds
No.
right now. Like I don't like taking them. I'd rather
Mm-mm.
I have the liquid version of them or something I can just
Mhm.
wolf down real quick. I'm not a big, but yes, they have a whole cut full of those things. And you're right on the eating. I mean, if you put Twinkies and a Coke in front of them, they're gonna take that thing out. But if you have, like, a salad and
Mhm.
so like, if I'm 80 something years old, that does not even sound good. It doesn't sound good right now to
Right.
me, let alone if I was
Yeah.
85.
When your
It's not like I'm
appetite's
some
down. Yeah.
yeah, it's not like somehow I'm gonna start liking salads when I turn
Yeah.
83. It's like, "Well, you know what? I like to just turn into a bunny. This is, like, really what I wanted to
Yeah.
eat," you know? So, there's so many things like that. There's so many people that have the polypharmacy side of things. There's so many residents that are falling, and we know that in this population, if they fall and they get a fracture, their outcomes and everything else and their overall health just declines,
Mhm.
starkly. Um,
Yeah.
Bleeding risk, I mean, you could go on and on and on about the things that you see. In fact, probably one of the biggest things that Caitlin said that is very true is sometimes you don't even know what it is that's causing all these things because of the load of meds that they're taking. And that kind of brings us into okay, Caitlin and Scott, that's wonderful.
Yeah.
But what in the world do we do with
What do we do?
this?
Yeah.
Right. Like, because I always love these podcasts or educational topics or whatever when people are like, okay, yeah, have a great day, everybody. And you're like sitting there going, "W
Uh,
you drop this
now what?
bombshell, but you don't yeah, now what do we do?"
Yeah.
So we're gonna talk about some ideas that you can implement within your facilities and, how you can work together with your consultant pharmacist, which is point number 1. As a pharmacist, our training was not in diagnosing people and all that kind of side of things. That's where a physician comes in, and we commend our physicians that are out there. If you're listening in on this, we commend you guys. Thank you for listening in on a pharmacist podcast. I think that's fantastic. But if you are interacting with your physicians, we don't want to bash them. They got a very difficult job of
Very. Mhm.
assessing them, treating them, and then like Caitlin was saying, they're coming in, we're all coming in, nurses, pharmacists, physicians, nurse practitioners, PAs are all coming in, and the list goes on. I don't want to leave anybody out, but we're all coming in at the end of that care cycle. And we haven't seen the other, 50, 60, 70 plus years that they've been on medication. So we don't really know what to get rid of, and so a physician has a very difficult time, and that's where the pharmacist
Mhm.
can come in, and we want to come in and help. If you're a doctor listening in, we want to help you. We're not trying to just cause you more paperwork. We really do want to help you, and so these pharmacist reviews are really important. I even think of all the reviews that we do when a resident has had a change of condition, so they fell, um had an altercation with another, resident or, there's a whole load and the list of things there, weight loss, unexpected weight loss or weight gain, just a huge amount of change of conditions that we can also review and make sure that meds aren't playing a role in that.
Mhm.
Um, you would be shocked. I think many of you that are not pharmacists that are on here and listening might be overwhelmingly shocked at how many meds can cause dizziness and drowsiness,
Yeah.
uh, and a lot of it at that. And especially like antibiotics are a huge one that can do that, right? And so that's where we can come in during the normal reviews. However, we call those IMRRs. Some groups call them different things like admit reviews and then interim medication regimen reviews is where IMRR stands for. But during the normal MRRs or medication regimen reviews, we can absolutely play a role in those as well. Looking at that anticholinergic burden, looking at the disease state management and saying, does this person really need 5 blood pressure meds to treat them? Uh, does this person really need all these pain meds? The other thing that we see, and this is kind of a kickback to the real world consequences, I guess this would be real world changes that we see in a resident, is when we start removing some of these excess meds, sometimes they come alive. Maybe
Yeah. Yeah.
they've been a little bit like, kind of. on the sidelines, but then they come alive and it's like,
Yeah.
who is this person? Who's Mrs.
Yeah.
Smith? Well, this is Mrs. Smith when she wasn't on drugs. It's like, this is your brain on drugs. This is Mrs. Smith not
Yeah.
on drugs, like those commercials back in the day.
Yeah.
But we see that. Um, and that kind of leads to something that we've talked about as well, deprescribing and non-pharmacologic alternatives. And Caitlin, tell our people, remind our people about deprescribing, med optimization, non-pharmacologic, that kind of stuff.
So it's looking at somebody's medication list and individualizing it to them. And it's not just about getting rid of meds. It is more about let's make this work for the resident and their specific conditions, their past medical history, and where they are in their condition today. So some medications may need to stay on, but maybe a lower dose. Some medications may need to be discontinued, while others may need to come on because there's better pharmacological therapies out there for that specific condition based off evidence-based practice. So it's optimizing the medications being used in combination for that individual person. It's not a one way or the other, we increase, we decrease, we get rid of. It's optimizing what we know based off evidence-based practice and applying that to them and their health to make the drugs work for them rather than against them.
Right, right. And that's a difficult process,
Yeah,
uh,
yeah.
absolutely difficult process. In that same kind of vein of thinking of optimizing meds is trying things that are not using a medication, which is our called non-pharmacologic therapy. That's where you'd try, sleep hygiene instead of a hypnotic, or um, you know, uh, doing some form of like, oh well, let's redirect that person instead of giving them a psychotropic med.
Right.
And sometimes that's effective, sometimes it's not. Obviously, we want to try to exhaust those options first before we try to add on a med. And I think that's where the education side of things comes in. So, obviously, as pharmacists, we know medications. Your physicians, your PAs, your MPs know the diagnosis side of things, they know the treatment side of things. And the two together, we can really bring different aspects of education to the facility staff as well as to family members. This is more of a assisted living setting or even some of the long-term cares where the family is really involved and wants to know about that person's overall well-being. Most people don't know medications, all right? Most people don't know anything about them, and you either have the people that are super not trusting of medications whatsoever, and so they just don't wanna hear anything about it. You've got kind of the in between, and then you've got the people that are like, "Yeah, just give them whatever. They want a quick fix," right? They want their loved one to not be, suffering or anything like that, which is admirable, but understanding kind of what is happening with that person and what will happen to their loved one if they start taking that medication and weighing those risks versus benefits is not always happening for these residents. And so, education from pharmacy staff for your facility, I can't promise anything on the other disciplines that are out there, but I can tell you that your pharmacy, pharmacist, consultant pharmacist want to help you and your facilities. Let us educate on disease state management. Let us educate on appropriateness of medications, inappropriate medications, things to look for, all of that. We could go into great detail on here, but there would be a podcast that basically everybody tune out or have to tune back in about 18 times too, just to process everything. But we can do that more individually at your facilities and want to do that. And I think I can speak for anyone that's in long term care, whether you are with our company or another company, that that's something that you desire to do. Because at the end of the day, what I know we believe here at Farm Care and what our consultant pharmacists hold near and dear is the care of the elderly residents, the sweet elderly residents that we're taking care of is first and foremost, right? So, education, alerts. We do a lot of things on our end to try to alert for high risk meds, to try to adjust doses when renal function is not as good or hepatic function is not as good, all sorts of things through our software that the pharmacy is also alerting the facilities about. And then I think you kind of end this saying that what is one of the most effective approaches at reducing these harmful drugs? Well, that's really taking this, Caitlin's mentioned this several times, as an individualized approach. There's not a cookie cutter like, well, we want to get rid of all the aspirins on file for all these people, right? May be appropriate, may not be appropriate. I had a home that was like, are all these multivitamins really benefiting the residents? Well, probably not. I mean, you
Probably
know,
not. But
some maybe, but
maybe.
most of them, it's probably coming right out in the urine, right? So
Yep.
it's expensive urine. But that may be something that is appropriate to get rid of some of the extra stuff on their profile. If they've got 10 or 15 drugs, it may not be appropriate for that person. It may be that that resident and their family feels we'll just take multivitamins because they're an easy one. No dog in the fight there, except if you make like Nature's Valley or something might come after us. But you know, maybe they want that on their loved one's profile
Makes
and
them
it's
feel
not
better.
hurting
Yeah.
anything, not having any big side
Mhm.
effects. That's probably okay. But maybe there's another med that we can get rid of that they don't really need anymore. And we see a lot of those PRN usage, things like that, that we're going, they don't need this anymore. That was a one time thing that's already passed, right? So there's a lot of individualized care approaches. I know our team really tries to do that. I tell our team all the time, you got all these criteria that's out there. We want to obviously pay attention to the criteria and know what the gold standard for treatment is, but we can't forget that there's individuals on the other end of that treatment that we're trying to recommend these different practices for, and it may or may not be what's in the best interest of that resident based on history and a slew of other things, other comorbid conditions they've got, et cetera. And so the takeaway from this is let us help you. Let us on all sides of this, the clinician side. I know many doctors have done the same kinds of things, going in and saying, "Well, this is why we're doing this or that." But let us on the pharmacy side help through med reviews, help through education,
Mhm.
help you and the residents and the family understand it a little bit better about what they're taking and the why behind it, and perhaps optimizing their med profiles a little more is the takeaway from this. I'm also staring at myself on this camera right now and realizing a comment
Mhm.
earlier that one of the consultants made to me, and you'll appreciate this, Caitlin. They
Oh,
were like, I mean, we'd been talking for a while, and all of a sudden they just paused and they said, "You look like that brawny paper towel commercial dude or guy."
with you, sure.
Yeah. And so, like, if you take it, it's not a lie because if you take that's how it looks on the deal, right? It's like he's
Yeah.
got the paper towel, but it's right on their front, and
Yeah.
all you don't see the eyes or the nose, it's just the mouth. If you were listening and you didn't see exactly what I did, but I basically held a piece of paper on my face, just like the silhouette of the brawny dude on the paper towels.
Yeah.
Yeah. Yeah, that was quite hilarious. I was, like,
That's funny.
looking at my shirt going, "Yeah, that's not far off from the truth." Well, listen, guys, from Caitlin and I, we hope that you guys are having a happy holiday season. Um, whatever you're celebrating, we hope that it's fantastic. Uh, we know that there's been news out there to not get gifts for people, but we won't
Yeah.
go into that too much. But, whatever you do and however you celebrate, we hope and pray that it is a wonderful month for you and time of year for you. Please be safe out there. And for all of you guys that are in the healthcare space and you're taking care of patients and residents, thank you for all that you do. You guys are incredible and you deserve hopefully a day off here and there this time of year to spend with your family. So hopefully you've got that on the books ready to spend that time. But we appreciate you guys listening in. This is a lot of fun for us to do and a lot of um, desire just to educate you guys and continue to do so. We would encourage you. Caitlin's going to soon have some of her YouTube shorts, med shorts out here pretty soon, which I think she just needs to not be so critical of herself. She's doing a
Hey.
fantastic job with them.
Yeah.
Um, but we want you guys to tune into those. We'll put a link in the show notes for those. They are a fantastic way to just listen. I mean, they're a minute long, guys. So what are you missing out on? You can miss the update from like your feed on TikTok or something like that that will not benefit you at all. You can replace it with a 1 minute or less video that will educate you in the setting that you're in. If you're in long term care, if you're looking at getting into long term care, great video series. And that's not just because Caitlin and I are doing it. That's part of it for sure, but it's not the only reason why we're plugging them. We're excited for those and more education to come, just like this podcast. So please follow us, like us, subscribe to the podcast, subscribe to our different channels and your different methods of listening of choice. Make sure you follow us on there, and we will have more and more coming after the holiday season. And so we look forward to that. And we'll see you guys next time.